Hello everybody, I'm going to be talking about new risks for invasive aspergillosis today. These are my disclosures. In summary, I'm going to talk about new risk groups in haematology. I'll also talk about new risk groups in other settings, in particular anti-TNF treatment and SLE, advanced cirrhosis, and the ICU setting. I'll also discuss viral infections and their impact on risk for invasive aspergillosis. So we know this is a table showing the well-known risks for invasive aspergillosis after chemotherapy in patients with hematologic malignancy. And you can see on the bottom two lines of the screen, we've got CLL and advanced myeloma. And these are areas where we're seeing a lot of new therapies. We're seeing patients receiving sequential therapies, and we're starting to see increased risk amongst these type of patients for invasive aspergillosis. So things are changing even in the haematology setting. There has been a rapid expansion of new treatments for hematologic malignancies, and these are just some of the drugs licensed by the FDA in 2017. All of these now have made their way into clinical practice. You can see there are monoclonal antibodies, and there are small molecule tyrosine kinase inhibitors, and many other new mechanisms of action that we're seeing in these drugs. One of the new small molecule kinase inhibitors is Ibrutinib, and this was really one that received quite a bit of attention for invasive aspergillosis and invasive fungal disease. We can see that it started being widely used in the last several years. Although the initial trials looking at Ibrutinib in treating patients with lymphoma and CLL didn't show any risk for invasive aspergillosis, certainly after marketing, there was observed an increased risk for invasive aspergillosis. And this led to this point of view being published in Clinical Infectious Diseases in 2018. And really this was based on the use of the drug in settings outside of clinical trials, where you were seeing patients with advanced disease, and it also being used in combination for conditions such as primary cerebral lymphomas. So attention suddenly turned to Ibrutinib and the risk for invasive fungal disease, and certainly many forms of fungal disease were seen, sometimes disseminated, and for example, CNS aspergillosis and disseminated aspergillosis. And going back to the mechanism of function of this drug, it was understood that it's impairing activation of neutrophils and TNF production could lead to an increased risk for aspergillosis, which wasn't initially appreciated in the clinical trials. We also looked at it in our setting, and this was a group of patients who had very advanced disease for CLL and were receiving it really after receiving many other lines of therapy. And we certainly saw increased risk for all types of invasive fungal disease, including Aspergillus in this group of patients. Again, a fairly unique type of patient group who had advanced disease. The other new therapies that we're seeing increasingly used are CAR T cells, and we know that there is an infection risk associated with this. Again, they're being used in patients with a more advanced malignancy, often lymphoproliferative diseases or acute lymphoblastic leukemia. These patients have often had a number of prior treatments, and the therapy itself is associated with lymphodepletion prior to administration of the CAR T cells, and after administration, cytokine release syndrome and neurotoxicity, or ICANS syndromes, which are adverse effects of the CAR T cells and are usually treated with corticosteroids and or tocilizumab. So we see in this group of patients receiving steroids or tocilizumab or both an increased risk for invasive fungal disease, but not overall in all patients receiving CAR T cell therapies. And many of the initial studies have used antifungal prophylaxis with either fluconazole or mycofungin. And so the rates of infection being reported from clinical trials have to be taken into account that these patients were already on antifungal prophylaxis, but not always mold-active prophylaxis. And this is a table summarising infections seen with CAR T-cell therapy from one study in Seattle. And you can see that the overall rates of invasive fungal disease were around 3%. And this was a population receiving fluconazole prophylaxis. Overall rates of mold infection about 1.5%. So not very high rates even in this heavily pretreated patient group. What about some of the other new therapies that we're seeing? Definitely seeing a number of new agents, including bispecific antibody therapies, P13K inhibitors, or BCL2 inhibitors such as venetoclax. And these are generally associated with low rates of invasive fungal disease, although because these agents are quite new, there's not a lot of post-marketing experience and identifying risks for invasive aspergillosis in this populations. We can see that certainly we do see some cases of aspergillosis, particularly in the venetoclax group, and again, more likely in those patients who've been heavily pretreated prior to receiving venetoclax. But overall, rates of infections from trials are around 1%. So how do we account for these new agents and what's a way to think about them? Well, I've just sort of created this little schema to think about it in my own mind when we see new treatments emerging and we're trying to assess what is the relationship with invasive fungal disease. We really need to take into account the host, the disease itself, and the treatment of the underlying disease. So that we can see, I've listed some of the factors here that increase the risks for the host of developing an invasive aspergillosis or an invasive fungal disease, including genetic markers, environmental exposure, and other conditions such as iron overload. Then when we think about the actual disease, whether it be CLL or ALL, we do think about whether it's relapsed or refractory disease, making the patient at higher risk for invasive aspergillosis, whether there are immune deficits associated with the disease itself, such as within CLL and myeloma patients, and also the presence of hypergammaglobulinemia. And then we also need to consider the treatment that the patient has received. So have they received only the drug in question, or have they received the drug plus combination of other anti-chemotherapy drugs? Then we have to think about previous lines of treatment and treatment side effects, such as we see with the CAR T-cell patients, where they may be treated with steroids, infliximab, or tocilizumab. So taking all this into account is how we have to assess an individual patient's risk when receiving one of these new agents and their risk for invasive aspergillosis. Well, turning away from hematological malignancies to some other agents that we know can be associated with invasive aspergillus, and one is certainly anti-TNF treatments. And there was a very nice study published some years ago looking at the different anti-TNF agents, and here we see infliximab and etanercept, and looking at the rates of invasive infections per 100,000 people treated with the agent. And you can see the rates here are actually quite small, but probably we do see more invasive aspergillosis with infliximab than, for example, with etanercept. So there's gradations across these agents in their risk for invasive aspergillosis, but overall the risk would seem to be relatively low with invasive aspergillosis and these agents, although present. Well, that can change again in different scenarios. And here's a case from a case report in a journal talking about a man who was treated with ipilimumab for metastatic melanoma, who developed colitis post ipilimumab. as an adverse effect of the checkpoint inhibitor, and then went on to receive methylprednisolone, prednisolone, and infliximab to treat the immune colitis secondary to the checkpoint inhibitor. And this gentleman did develop invasive aspergillosis. And you could see the development of this cavity here and the subsequent regression of it on antifungal treatment. So again, this is an example of infliximab in combination with other immune suppression, such as corticosteroids, and heightening the risk for invasive fungal disease. There's also been some nice studies looking at other connective tissue diseases, such as lupus, and showing that there is a small but appreciable risk for invasive aspergillosis in these settings. You can see here in a very large survey of adult SLE patients a rate of proven and probable aspergillosis of around 0.3%. And they could identify that this was actually more common in patients receiving pulsed steroids or azathioprine, rituximab, plasmapheresis, and who had ARDS or CMV viremia. So again, a conglomeration of risk factors really putting these patients at higher risk for invasive aspergillosis. And in this survey, there was also an opportunity to look at paediatric SLE patients who had a rate also of slightly higher at 1%, again related to disease activity and glucocorticoid use. So again, thinking of patients outside that hematology setting, we're certainly seeing aspergillosis, particularly in patients who have active disease and receiving heavy immunosuppression. Another group of patients that's been recently looked at is patients with advanced cirrhosis and liver disease. And one survey in medical ICUs looked at patients with cirrhosis admitted with respiratory failure to the ICU and undertook routine CT scans and BALs on these patients and found a rate of invasive aspergillosis of around 14% in these patients. And it was probable invasive aspergillosis with the clinical radiological features and the mycology seen on bronchoscopy or on serum galactomannan. So these patients did have a higher mortality, very high mortality, than patients without aspergillosis, and was more likely in those with more severe and advanced disease. I'd like to turn a little bit more towards viral infections because that's a theme that keeps coming up with these patients who are not in the classical risk groups, but where viral infections may predispose the patient to developing an invasive aspergillosis. So the first real discussion about this in patients outside of hematological malignancy and transplant was really the finding of aspergillosis complicating influenza in the ICU. And there were several observational studies identifying a risk for invasive aspergillosis in patients who were ventilated or with respiratory failure in the ICU. And this was true for both influenza A and influenza B, but also for the immunocompromised and the non-immunocompromised, although the rate was higher in patients who were immunocompromised than it was in the non-immunocompromised, where the rate was about 14%. So apart from influenza, what other viral infections are associated with increased risk for invasive aspergillus? Well, we know CMV is, and we've identified that for quite some time in the hematology and solid organ transplant setting. And this is just one study showing that patients with high CMV area under the curve as determined by antigenemia, and this was a function of both the duration of antigenemia and the degree of CMV antigenemia, had the highest risk for subsequent invasive aspergillosis, even higher than patients with acute graft versus host disease. And this was seen also in the absence of graft versus host disease, this risk associated with CMV and invasive aspergillosis in allogeneic stem cell transplant. Similar findings in the solid organ transplant in this large meta-analysis. Again, in all types of solid organ transplant, the association was seen between CMV and invasive aspergillosis. Also in another study from Taiwan, in critically ill patients, many of whom didn't have malignancy but had chronic kidney disease or connective tissue disease. And this was a study where patients were intubated in the ICU and bronchoalveolar lavage was tested for galactomannan and CMV viral loads simultaneously. And it was found that those patients with the highest viral loads were at the greatest risk for invasive aspergillosis. Other respiratory viruses in the hematology setting have also been associated with risk for invasive aspergillosis. And these are the common respiratory viruses that we see in the community, such as RSV, parainfluenza, etc. And here again, there was an increased risk in the allo transplant patients related to timing post-transplant, lower respiratory tract infection, and use of ATG. So again, other viruses besides influenza and CMV. And of course, we've recently learnt about COVID-19 infection and invasive aspergillosis, or kappa. And there's been many studies of this condition. Two I'll highlight here is a summary of all the published papers done by Aristophar, which looked at studies globally and identified over 300 kappa cases, all of which were diagnosed in the ICU with a mortality up to 100%. And a subsequent European registry study, which looked at 20 centres and showed that the prevalence of kappa in these centres in patients in ICU was 15%, with a 54% mortality. But interestingly, this study found quite a variation in rates of kappa between different centres, which is yet unexplained. So there has been quite a discussion about what it is that associates respiratory viruses, including COVID and influenza, with the risk for invasive aspergillosis. And of course, there's the airway epithelial damage, but there's also hyperinflammation in response to these infections. And the etiology for both seems to go through this common pathway of hyperinflammation, followed by immunoparalysis after the hyperinflammation. And so I think both of these pathogenic pathways actually offer potential ways of intervening to potentially prevent invasive aspergillosis. So this is an area, a very in-depth study currently. There is a definition recorded for kappa, and this was a consensus definition put out last year by ECCM and ISHAM. And again, not really conclusive, I'd say, at this time. Some debate about whether we can, in fact, define possible aspergillosis on non-bronchoscopic lavages, and really what the cutoff on these type of non-bronchoscopic tests should be. There's really no debate about proven pulmonary or tracheal, which is histopathological diagnosis, and probable where you also have both radiology and microbiological confirmation from BAL. So I think these are really a great advance to trying to collect more complete and comprehensive data relating to kappa following our COVID infection in our patients. And I think that we'll see more discussion about the validation of these types of definitions as time goes on. So, in conclusion, for this discussion, we've talked about invasive aspergillosis. It's still the most common invasive fungal disease in hematologic malignancy, and newer treatments are emerging which are not particularly associated with higher risks for invasive aspergillosis, but we do need to be aware of them occurring, particularly in subgroups of patients who we can identify as being at higher risk, such as CAR T-cell patients who are receiving enhanced immune suppression, such as steroids and tocilizumab. We've talked about the emerging new risk groups, particularly those in the ICU who are ventilated. An example of these is patients with cirrhosis or SLE, COPD, and the COVID and influenza patients. And we've talked about the fact that there are now definitions being put forward for these patients for invasive aspergillosis and for defining invasive aspergillosis in these patients who do not have classical risk factors but do require ventilation. And these definitions will require validation over time. But I think the key message is to maintain an index of suspicion for invasive aspergillosis in the immunocompromised patient, other than those with hematologic malignancy. And of course, as always, making a timely diagnosis is critical, and thus the need to have an index of suspicion outside of these classical risk group patients. Thank you.
Yes. Do we have you online, Monica?
Yes, thanks, Lewis. I'm here.
Hey, great to see you. Yep. So
Hey.
yeah, we would have loved to have you back in Singapore. I know you love Singapore, and we are always very glad to have you grace many of our meetings, and of course catching up one-to-one. But of course we'll do it the next time around. So let me just go through if there's any questions from any of our participants, or if there's anyone live here who would want to ask any questions. Okay, so while we are waiting for questions, I think Monica, you have brought up very pertinent points with regards to biologics and opportunistic infections, in particular invasive fungal. So I think one of the major challenges that we have had, and I'm sure both many of us mutually share it, is actually with the advent of biologics that actually kick up a cytokine storm, and of course classically with CAR T, and even more so now with the BiTE therapies, especially those that combines CD3 and CD20, and whereby one of the biggest challenges is actually to distinguish between hyper-inflammatory response versus a real infection, or even in the worst case scenario, actually a double whammy with both infection and hyperinflammation. So I was just wondering if you may be able to share with us, your experience and how that may be tackled, because that's basically an extremely tricky, challenging situation that we face where we practice. Over.
Yes, I agree, Lewis. It's very tricky. These patients do get cytokine storm, and of course then they're treated with steroids and other immunosuppressants. So often the cytokine storm is the precursor to an infection, and so it is very difficult to tease out when the patient has an infection versus a cytokine release syndrome. So I think at the moment we don't really have good ways of doing this, and I think we need some immunological studies to look at if there are any particular markers we can use. I don't think procalcitonin is really that helpful in this situation, but whether there is a motif of cytokines in the blood that we could use to predict infection versus cytokine release, I think still requires some more study. Of course, our rapid diagnostic tests will also be more useful in this scenario, where we can use potentially very rapid diagnostics, such as even genomic-based diagnostics. But again, that's all in the future. So for the moment, we're really just left with our clinical acumen, and we'll often start antibiotics. And then if our tests are all negative, try and stop them in 48 hours or so. So it is an area, I think, for both antimicrobial stewardship and better diagnostics to help us in this scenario.
Sure. Thank you very much, Monica. In fact, when talking about clinical acumen, so you're one person whom we always look up to when it comes to clinical experience. So with this, I don't see any more questions up online. And so I have to thank Monica once again for gracing the occasion here at APCCMI, be it in person or remotely from Melbourne. So thank you very much once again, and just a round of applause for Professor Monica Slavin for the talk.
Thank you, Lewis. It's a great pleasure to be here. Hope to see you in person soon, and all the colleagues in Singapore.
Absolutely.
Bye.
Thank you very much. Bye-bye. Yeah, thank you.
Bye.